Okay, friends in the psych community, here is the treatment plan for a few Z codes or diagnosis codes, where we randomly select a Z code or diagnosis code and figure out how some therapists, including myself, would treat a client with that either Z code or diagnosis code. So this is a book called The Complete Adult Psychotherapy Treatment Planner. Now, I do use some of these interventions and objectives in my own practice and utilize some other stuff that are not in the book. It's really helpful for therapists to have a sense of guidance to help guide their own patients. So here we have, let's choose a random Z code. Last time we did a diagnosis, today we'll do a Z code. And let's do this one. Everyone feels it, unfortunately. Financial stress. Alright, so behavioral definitions of financial stress. Indebtedness and overdue bills that exceed ability to meet monthly payments, loss of income due to unemployment, reduction in income due to change in employment status, conflict with spouse over management of money and the definition of necessary expenditures and saving goals, conflict, a feeling of low self-esteem and hopelessness that is associated with the lack of sufficient income to cost the cover of living, a long-term lack of discipline and money management that has led to excessive indebtedness, an uncontrollable crisis, medical bills, job layoffs, that has caused past due balances to exceed ability to make payments, fear of losing housing to foreclosure because of an inability to meet monthly mortgage payments, and a pattern of impulsive spending that does not consider the eventual financial consequences. So the long-term goals would be to revise spending patterns to not exceed income, resolve financial crisis with a path to eliminate debt, gain a new sense of self-worth, in which the substance of one's value is not attached to the capacity to do things or own things that cost money. Understand personal desires, insecurities, and anxieties that make overspending possible. Achieve an inner strength to control personal impulses, cravings, and desires that directly or indirectly increase debt irresponsibility. So, one thing I would like to add is adding the spouse, if there is a marriage couple or non-married couple, to come into that session to work on financial goals together, and you would play a mediator, because unfortunately in this book they missed that, as financial stress is the number one stress that can lead to divorce. Okay, short-term objectives. Describe the details of the current financial situation, isolate the sources and causes of the excessive indebtedness, and verbalize feelings of depression, hopelessness, and or shame that are related to financial status. So here are the therapeutic interventions on how to tackle those objectives. So the interventions would be providing the client a supportive and non-judgmental environment, explore the client's current financial situation, assist the client in compiling a list of financial obligations, assist in identifying without projection of blame or holding to excuses the causes of the financial crisis through review of the client's history of spending, probe the client's feelings of hopelessness or helplessness that may be associated with the financial crisis, assess the debt or seriousness of the client's despondency over the financial crisis. Number 4 objective. Describe any suicidal impulses that may accompany financial stress, and assess the client's potential risk for suicidal behavior. If necessary, take steps to ensure the client's safety. And then identify personal traits that make undisciplined spending impossible. So probe the client of evidence of low self-esteem, need to improve others, loneliness or depression that may unwarranted spending. Assess the client for mood swings that are characteristic of bipolar disorders and could be responsible for careless spending due to the impaired judgment of a manic phase. This is unfortunately one of the most common manic episodes that you would see in the bipolar disorder. Number 6, objective. Honestly describe any of own family members' substance abuse problems that contribute to financial irresponsibility. And number 7, provide behavioral, emotional, and attitudinal information toward an assessment of specifiers relevant to a DSM diagnosis, the efficacy of treatment, and the nature of the therapy relationship. So, how to get to the point of understanding the family member's own substance abuse problems. If related to the financial stress, you would probe the client for excessive alcohol or drug use by asking and assessing through the CAGE screening instrument for substance abuse, and explore the possibility of alcohol or drug use by the client's family members or significant other. This makes it all the more dangerous if they are blowing off finances on alcohol or drug use. Assess the client's level of insight, syntonic versus dystonic. So syntonic means knowing they have a problem, and dystonic means assuming they don't have a problem. You're less likely to see clients in front of you if you have a dystonic diagnosis of a patient, as they don't feel they have anything wrong with them. So it's quite scary. Anyways, good insight into the problematic behavior, or the described behavior agrees with others' concerns and is motivated to work on the change. That is a syntonic diagnosis. Number 13, assess the client for evidence of research-based correlated disorders. Oppositional defiant disorder, which we mainly see in children, so this would be a long-lasting diagnosis, comorbid with ADHD, depression secondary to an anxiety disorder, including vulnerability to suicide if appropriate. And then you would again assess risk from there. Assess for any issues of age, gender, or culture that could help explain the client's currently defined problem behavior and factors that could offer a better understanding of the client's behavior. Assess the severity of level impairment to the client's functioning to determine appropriate level of care. So we're going to assess for the severity in social, relational, vocational, or occupational endeavors, and continuously assess for that severity. Number 8, objective, identify priorities that should control how money is spent. And number 9, objective, describe the family of origin pattern of money management. So the interventions to accompany that, ask the client to list the priorities he or she believes should give direction to his or her money to be spent on, and process those priorities. Review the client's spending history to discover what priorities and values have misdirected spending, and explain the client's family of origin patterns of earning, saving, and spending money, focusing on how those patterns are influencing his or her current financial decisions. Number 10, meet with the community agency personnel to apply for welfare assistance. So we would review the client's need for filing for bankruptcy and applying for welfare or obtaining credit counseling, and direct the client to the proper church or community resources to seek welfare assistance and support his or her beginning in the humbling application process. Refer the client to government home buyers, homeowners assistance programs to avoid foreclosure. And the objective for number 11, write a budget that balances income with expenses. Number 12, objective, attend a meeting with a credit counselor to gain assistance in budgeting and contacting creditors of establishment, a reasonable repayment plan. And number 13, meet with an attorney to help make a decision regarding filing for bankruptcy. So we would do financial planning in sessions, or even asking their partner to write a current or budget and a long range of savings and investment plan. We'd review the client's budget as to reasonableness and completeness. We'd refer the client to a nonprofit or no-cost credit counseling service for the development of budgetary plan of debt repayment, and encourage the client's attendance at all counseling sessions, credit counseling sessions, and discipline of self-control, spending within budgetary guidelines. And then we would refer the client to an attorney to discuss the feasibility and applications of filing for bankruptcy, if that's the route you guys would take. Verbalize a plan for seeking employment to raise level of income would be objective number 14. And 15, set financial goals, make budgetary decisions, and partner allowing for equal input and balance control over financial matters. Keep weekly and monthly records of financial income and expenses, and use cognitive behavioral strategies to control the impulse to make unnecessary and unaffordable purchases. The interventions for those objectives: review the client's income from employment and brainstorm ways to increase the revenue. So if that means helping finding a part-time job, better paying job, or job training. Assist the client in formulating a plan for a job search. Encourage financial planning by the client that is done in conjunction with their partner. Reinforce changes in managing money that reflect compromise, responsibility planning, and respectful cooperation in the client's partner. Encourage the client to keep a weekly and monthly record of income and outflow. Review the records and reinforce his or her responsible financial decision. Offer praise and encouragement the client's progress towards debt solutions. Role-play situations in which the client must resist the inner temptation to spend beyond reasonable limits, emphasizing positive self-talk that complements self for being disciplined. Role-play situations in which the client must resist external pressure to spend beyond what she or she can afford. Example, if a friend's invitation to go golfing or shopping. Child's request for a toy, emphasizing being graciously assertive and refusing the request. Number 35, teach the client the cognitive strategy of asking self before each purchase. Is this purchase absolutely necessary? Can we afford this? Do we have the cash to pay for this without incurring any further debt? 36, urge the client to avoid all impulses buying by deleting every purchase until after 24 hours of thought, and by buying only from pre-written lists of items to buy. Number 18, the last objective, report instances of successful control over impulse to spend of unnecessary expenses. The last two interventions you may portray in a session: reinforce with praise and encouragement all the client's reports of resisting the urge to overspend. Hold conjoint or family therapy session in which controlled spending is reinforced and continued cooperation is pledged by everyone. So while that is a Z code, it is can be suggested with a DSM disorder as an added sort of reason as to why the financial stress Z code is there. So it could be, like we mentioned, the bipolar disorder of a manic episode, bipolar 1 specifically, and then adjustment disorder with depressed mood, due to that dopamine, wanting that dopamine with overspending, major depressive disorder, a whole list of things that could lead to the possibility of that financial stress Z code. Now, one thing this book does not tackle is financial anxiety, which would be very, very strongly related to a diagnostic suggestion of the generalized anxiety disorder. This is something you'd most commonly see in mostly everyone, whereas this financial stress sounds like it would be more focused on people that put themselves in debt. So this is what it would look like to treat someone that is coming in for financial stress or came in for one of these diagnoses that also have financial stress as a different issue that can be causing it hard, causing other issues in their life, making it hard to treat their diagnosis. And so it is important to manage all problems in addition to their ICD-9's codes. In this situation, it would be ICD-9 or ICD-10 code. Okay, that's it for today. And that was just therapist reading random contents from the Complete Adult Psychotherapy Treatment Planner. I really like this as a resource. I utilize it in my sessions, and in between sessions, my clients can utilize it for homework. I don't follow it step by step, but I like to use it as ideas. Ultimately, it is a very good tool for a therapist, because a therapist should be doing at least 5 interventions per session. Let's see, which diagnosis should we do today? So this is a great tool for therapists when it comes to setting up a treatment plan for a client. A treatment plan usually should be written within the same day of a session, the first initial session with a client, and would be kind of altered as you go. It's a very important tool to have, and sort of guidance to know how you're supposed to treat the client in order to get them to feel better. Okay, well, let's do this one. The heavy one today. Today, let's read about how to treat someone with dissociation. The existence. Now, this is actually a very interesting diagnosis because it does get misconstrued in a lot of ways, especially in the media, online. So this is very important to understand what disassociation actually means. Here we go. Behavioral definitions. The existence of 2 or more distinct personality states that currently take full control of one's behavior. An episode of the sudden inability to remember important personal identification information that is more than just ordinary forgetfulness. Number 3, persistent or recurrent experiences of depersonalization, feeling as if detached from others outside of one's own mental processes or body, during which reality testing remains intact. Number 4, persistent or recurrent experiences of depersonalization, as in feeling as if one is in a dream. Depersonalization sufficiently severe and persistent as to cause marked distress in daily life. So the long-term goals in treating someone with a dissociative disorder. Number 1, integrate the various personalities. Number 2, reduce the frequency and duration of dissociative episodes. Number 3, resolve the emotional trauma that underlies the dissociative disturbance. Number 4, reduce the level of daily distress caused by dissociative disturbances. Number 5, regain full memory. So, short-term objectives. Identify each personality and have each one tell its story. Number 2, complete psychological testing designed to further understand the nature and extent of dissociative experiences and personality. Number 3, cooperate with a referral to a neurologist to rule out organic factors in amnestic episodes. So let's go through the interventions on how to tackle those first 3 objectives. Actively build the level of trust with the client in individual sessions through consistent eye contact, active listening, unconditional positive regard, and warm acceptance to help increase his or her ability to identify and express feelings. Number 2, without undue encouragement or leading, probe and assess the existence of the various personalities that take control of the client. Number 3, conduct a functional analysis of the variables associated with the dissociative states and their resolution, including thoughts, feelings, actions, personal variables, consequences, and secondary gains. Number 4, conduct or refer for psychological testing of dissociation and or abnormal and normal personality features and traits. Number 5, refer the client to a neurologist for an evaluation of an organic cause of memory loss experiences. Number 4, objective. provide behavioral, emotional, and attitudinal information toward an assessment of specifiers relevant to the DSM diagnosis efficacy of treatment and the nature of the therapy relationship. So, interventions to support that. Assess the client's level of insight, syntonic versus dystonic, towards the presenting problems. If he agrees in the described behavior, is motivated to work on the change, demonstrates ambivalence regarding the problem described, and is reluctant to address the issue as a concern, or demonstrates resistance overall regarding acknowledgement of the problem described and is not concerned, it is not motivation to change. Assess the client for evidence of research-based correlated disorders, oppositional defiant behavior with ADHD, depression secondary to an anxiety disorder, including vulnerability to suicide if appropriate. Increased suicide risk with comorbid depression is evident. Number 8, assess for any issues of age, gender, or culture that could help the client's currently defined problem behavior, factors that could offer a better understanding of the client's behavior. Number 9, assess the severity of the level of impairment to the client's functioning to determine appropriate level of care. The behavior notes creates mild, moderate, severe, or severe friendly impairment in social, relational, vocational, or occupational endeavors. Continuously assess the severity of impairment as well as the efficacy of treatment. And number 5, objective. Create a psychotropic medication evaluation with a physician. Number 6, take prescribed psychotropic medications responsibility at times ordered by the physician. Number 7, participate in therapy to address personal and interpersonal vulnerabilities to dissociation. Number 8, identify the key issues that trigger a dissociative state. So the interventions to support those: arrange for an evaluation of the client for psychotropic medication prescription. Monitor and evaluate the client's psychotropic medication prescription for compliance, effectiveness, and side effects. In clients whose dissociation appears functionally related to clinical syndrome, PTSD, or personality disorder like borderline personality disorder, conduct or refer to evidence-based treatments of the disorder, cognitive processing therapy, or dialectical behavioral therapy. Number 13, explore the feelings of traumatic circumstances that trigger the client's dissociative state. Number 14, explore the client's sources of emotional pain or trauma and feelings of fear, inadequacy, rejection, or abuse. Number 15, assist the client in accepting a connection between his and or her dissociating and avoidance of facing emotional conflict issues and painful emotions. Number 8, objective, decrease the number and duration of the personality changes. How to support that? Facilitate integration of the client's personality by supporting and encouraging him and her to stay focused on reality rather than escaping through dissociation. You can also assign staying focused on the present reality from the adult homework version of this book. Number 17, emphasize to the client the importance of here and now focus on reality rather than a preoccupation with the traumas of the past and dissociative phenomena associated with that fixation. Reinforce instances of here and now behavior. Number 10, for objective, practice relaxation and deep breathing as means of reducing anxiety that serves as a trigger for dissociation. So we would teach the client calming techniques like progressive muscle relaxation, breathing-induced relaxation, calming imagery, cue controlling relaxation, and applied relaxation as part of a tailored strategy for reducing chronic and acute psychological tension that triggers dissociation. Number 19, role-play the use of relaxation and cognitive coping to visualize stress-provoking scenes, moving from low to high stress scenes. Assign the implementation of calming techniques in his or her daily life when facing these trigger situations. Process the results reinforcing success and problem-solving obstacles. Number 20. Assign the client to read about progressive muscle relaxation and other calming strategies in relevant books or treatment manuals. Objective 11. Identify challenge, replace self-talk that produces negative emotional reactions with self-talk that facilitates a better regulation of emotions. So how can we support that? Explore the client's self-talk that mediates his or her strong negative painful feelings and actions. Example, I can't face this. Identifying challenge biases, assisting him or her in generating appraisals and self-talk that corrects for the biases and facilitates a more realistic and regulated response. Combine new self-talk with calming skills as part of developing coping skills to manage negative emotions. 22. Roleplay the use of relaxation and cognitive coping to visualized emotion-provoking scenes, moving from low to high challenge scenes. Assign the implementation of calming techniques in his or her daily life when facing trigger situations. Process the results, reinforcing success and problem-solving obstacles. 23. Assign the client a homework exercise in which he or she identifies biased self-talk and generates alternatives that help moderate emotional reactions, review while reinforcing success, providing corrective feedback toward improvement. Number 12 objective. Verbalize acceptance of brief episodes of dissociation as not being the basis for panic, but only as passing phenomena. So, teach the client to be calm and a matter of fact in the face of brief dissociative phenomena so as to not accelerate anxiety symptoms, but to stay focused on reality. So that basically means labeling it. 25. Intervention. Use an ACT approach. So that means acceptance and commitment therapy. Use an ACT approach to help the client experience and accept the presence of painful, troubling thoughts and feelings without being overly impacted by them, and committing his or her time and efforts to activities that are consistent with identified personal meaning values. Teach mindfulness meditation to help the client change his or her relationship with painful thoughts and their feelings, building acceptance of them without undue reactivity. 27. Assign the client homework in which he or she practices lessons in mindfulness meditation and ACT in order to consolidate the approach into everyday life. 28. Assign the client reading consistent with mindfulness and ACT approach to supplement work done in session. 13th objective. Discuss the period preceding memory loss and the period after memory returns. So how would we do that? Explore the client's sources of emotional pain or trauma and the feelings of fear and of inadequacy, rejection, or abuse, and describing the trauma. And then arrange and facilitate a session with the client and significant others to assist him or her in regaining lost personal information. The 14th objective. Utilize photos and other memorabilia to stimulate recall of personal history. So calmly reassure the client to be patient in seeking to regain lost memories, and review pictures and other memorabilia to gently trigger the client's memory recall. So this would all be done in a possible depersonalization disorder, dissociative amnesia, dissociative identity disorder, maybe alcohol dependence, dissociative disorder, NOS, and ultimately maybe even severe cases of PTSD in addition to the dissociative disorder that can cause blankets of memories that cannot be attained, and the client may exude panic attacks and won't know why. Highly recommend, in addition to these interventions and objectives, would be working closely not only with the patient's medical care team, but another therapist for them to also most likely utilize a dialectical behavioral therapeutic approach. And yeah, this is dissociation. Thank you for listening. We'll be back to read another random treatment plan of a few diagnostics listed in this book. Alright, well, that's it for today. Thank you very much.